So thank you for joining us. Please bear with us, and as we wait for other people who are still connecting, as we can see, we'll request that you just start by introducing yourself in the chat, and we will get started in a few seconds. All right. I guess we can start and wait for other people to join. I wanted to start by saying good morning and good afternoon or good evening, depending on where in the world you are joining us from. And we appreciate that many of you are making time to join us. So a very warm welcome from the Prevention Collaborative to this webinar. And I know many of you may know the Prevention Collaborative, but for those who may not be familiar with us, I'll start with a quick introduction. The Prevention Collaborative is a global organization that aims to strengthen the field of violence prevention against women and their children by connecting research, evidence, practice-based knowledge, and programs. We work to strengthen the capacity of key actors to design, deliver, and advocate for cutting-edge prevention programs informed by research-based evidence, practice-based learning, and feminist principles. So thank you for joining us today. I am Rita Nyiratunga. I work with the Prevention Collaborative, and I'm based in Kigali, Rwanda. Today, with support from my colleagues, Ruti, Tanya, I will be moderating the webinar. I'll quickly introduce the topic of the day. As you can see on the screen, we'll be talking about pathways between poor mental health and intimate partner violence. Poor mental health is a key driver of both experiencing and perpetrating intimate partner violence, as we name it, IPV. And although still limited, evidence suggests that efforts to improve mental health could be a critical IPV prevention strategy. With our speakers today, we'll be learning more about the evidence, pathways, and promising approaches for change. Before maybe I introduce our speakers, I would like to give some meeting etiquette for you to be aware of. We will be using a question and answer box, and we'll invite you to share your questions so the panelists can see the questions and take time to respond. Please make sure that you are posting your questions to all if you're using the chat box so everyone can see them. I also wanted to flag that this meeting is being recorded for the sake of those who may have wanted to be with us but are unable to do so today. So if you want to voice your idea and for some reasons you do not want to be captured in the final recording, let our team know and we'll handle that. Would also like to ask you to introduce yourself in the chat so we know who is here and create that sense of being in the same room. So now please share your names and as you join, and I'll give a quick introduction of who is going to talk to us today. All right, so as I said, to talk about this topic, we have Dr. Rukudzo Mwamuka, who is a psychiatrist living and working in Zimbabwe. She has experience in community mental interventions drawn from the 2 years that she worked with the Friendship Bench. She'll tell us more about that. In her role as the clinical programs manager, Dr. Rukudzo provided oversights and strategy for the implementation and scale-up of the Friendship Bench intervention. She is currently the head of department at Sally Mugabe Psychiatric Hospital, and she holds a medical degree and a Master of Medicine degree from the University of Zimbabwe. Thank you so much, Dr. Rukudzo, for being with us today. We're also with Dr. Erin, who is an associate Senior Associate at the Prevention Collaborative. Erin has 14 years of research experience to inform and evaluate gender and health programs. She has provided implementation or research support to a range of NGOs and agencies. Erin has a PhD in public health from the University of Cape Town and holds honorary positions with the University of Cape Town and the London School of Hygiene and Tropical Medicine. We're pleased to have you with us, Erin, and thank you so much for making time. So now, without any further ado, I will hand over to Erin to take us through the first part of the presentation they prepared for us. Thank you so much. Over to you, Erin.
Thanks so much, Rita, for the introduction, and thank you so much to all of you making time to be here. We're really excited to launch this piece of work. Links will be shared in the chat, but this evidence review and a summary brief have just been launched on the Prevention Collaborative website. I will try to do justice to it in a quick overview, but please, I hope that you are interested and can learn more after this conversation. I'm really excited to be launching this work today. So next slide, please, Mudo. So just in terms of the background of this brief and what this review really covers, there's a lot of evidence, and I know many of us here in the room either come from the violence prevention field or the mental health field, and I'm sure everyone is quite aware of the evidence suggesting that experiences of intimate partner violence contributes to a range of adverse mental health outcomes, including anxiety, depression, post-traumatic stress disorder, and at its most extreme, suicidality. As a reverse pathway, there's also increasing evidence that poor mental health can be a significant risk factor for both perpetrating and experiencing intimate partner violence. And so this review examines this latter pathway, which we think there's less attention to, and focusing it on intimate partner violence and the potential role that improving mental health, even at a wider population level, including among men, could play as a prevention strategy of intimate partner violence. One thing to note with this review, we specifically address common mental health problems. These include depression, anxiety, and trauma-related symptoms. And these are extremely prevalent globally, so it's also very relevant when thinking about a violence prevention strategy. More complex or other mental health disorders, including things like schizophrenia and bipolar disorder, that require specialized care are beyond the scope of this review and so not included. And so next slide, please, Mudo. So one thing we wanted to just note, and I think why there is less attention to this reverse pathway, so the ways in which poor mental health can be a risk factor for perpetrating or experiencing intimate partner violence, is due to a number of reasons. Historically, this framing could be used to blame IPV survivors or delegitimize women's experiences, kind of linking it to, oh, it's just a manifestation of poor mental health. And so there has been some kind of previous concerns, particularly from feminist groups, around emphasizing the linkages between poor mental health and risk for experiencing IPV. I think more recently, there have been concerns that emphasizing these links risks individualizing a fundamentally, as we know, societal problem when it comes to intimate partner violence, or could avoid holding perpetrators accountable for their actions. Emphasizing the links between poor mental health and risk factors for violence could potentially also stigmatize problematically people with mental health problems or create barriers to their seeking care. And so it's just really important to recognize this and of course acknowledge that while mental health problems can increase the likelihood of IPV, the link is by no means inevitable. It's just a risk factor. And it's one of multiple overlapping factors that can contribute to the likelihood. So when you think about, I'm sure many of us in the room are familiar with models like the socio-ecological model to IPV. This is just one of many factors that might be underlying the intimate partner violence with the communities or individuals you're working with. But we do think that to minimize or to kind of overlook these links misses a really valuable opportunity to intervene effectively to reduce and address the consequences of both problems. And both problems, as we know, both intimate partner violence and common mental health problems are extremely prevalent globally. So we think there's a real potential here. So just to frame that before we begin. So next slide, please, Muvo. So what we've done with this review, and there's, as I said, in the review that's been published, it goes through this in much more depth. We've developed and laid out this diagram. So this kind of top level looks at, well, how do we explain why common mental health problems, or what are the common pathways in which common mental health problems can increase the likelihood of both experiences and perpetration of IPV? And then we also identify some of the underlying structural or risk factors of common mental health problems. And for those of you who kind of come from the violence prevention field and maybe work less in mental health, you'll recognize a lot of these as significant structural drivers of intimate partner violence as well. So again, I think speaks to the potential linkages of interventions that are addressing both. So I'll go quickly through a few of these just to identify what they are. Again, the review has much more detail and just tries to synthesize some of the evidence to illustrate this diagram. So on the left here, we have poverty and food insecurity in the purple left, in terms of starting with the underlying factors of what really drives common mental health problems, including depression, anxiety, and trauma-related symptoms. Really, that's the focus of this review. So poverty, there's a lot of evidence that this can exacerbate poor mental health through many factors, including just daily stressors, loss of income, food insecurity, and inadequate or overcrowded housing. Poverty is also associated with worse physical health. It can lead to greater exposure to violence, crime, and lower social status, all of which can affect mental health. And poverty and food insecurity, when thinking about some of the gender differences, is a particular mental health risk for women, and also a risk factor for their exposure to intimate partner violence. In many settings, however, there's normative expectations on men to be the breadwinner can exacerbate negative mental health consequences among men who face insecure livelihoods and food insecurity. So that's that one pathway. With the other factor here, we have patriarchal norms and gender inequalities. So this kind of recognizes that women are more likely than men to experience common mental health problems, with women living in low and middle income countries especially vulnerable. And this can be partially explained by gender-based inequalities that disadvantage women, and by their higher likelihood of exposure to gender-based violence, including intimate partner violence. At the same time, dominant constructions of masculinity in many settings typically hinder men's willingness to seek help for mental health problems, and mental health services that do exist are often not regarded as male-friendly. This structural factor also acknowledges the ways in which gender intersects with other forms of inequalities and discrimination that can generate mental health consequences. So including related to race and ethnicity, gender orientation, gender identity or sexual orientation, disability, and immigrant status. So the next structural factor in the middle here in the yellow is conflict and environmental insecurities. So we know that exposure to conflict, post-conflict, high violence settings, or stress from displacement increases the risk of trauma and mental health problems. And as we know, also can increase the risk of experiences of gender-based violence. This factor recognizes the ways in which climate change or extreme natural disasters can impact mental health and lead to significant trauma. And I think with the COVID pandemic, this also recognizes things like the COVID pandemic and the anxieties related to the pandemic have been very strongly linked to increased risks of trauma, poor mental health, and also increased risks of gender-based violence. The other structural factor in this diagram is lack of social support. So this green one on the far right. And this refers to a lack of social support, both emotional and more practical support, and how this can be a risk factor for poor mental health. So in terms of thinking of some of the more practical sides of social support, an example is how reduced access to just social safety nets. So whether there's food banks in your community or income support, family or friends who can offer loan, kind of people that can hold you up if you are, in the midst of adversity. If you don't have much access to that, it can increase the likelihood of developing mental health problems. Conversely, having access to social support can be a protective factor and buffer against developing poor mental health or common mental health problems. And then the final structural factor in this diagram is childhood trauma and adversities. So this looks at some of the evidence around how adverse childhood experiences and trauma, including exposure to violence as children, can actually alter the developing brain and neurodevelopment, and in doing so, predispose a child to subsequent anxiety and depression. There's also a lot of evidence that early trauma can influence the development of what's known as avoidance symptoms. This can lead to things like self-medicating with alcohol or other drugs, decreased interest in friends and family or expressing intimacy, so under avoidance symptoms, and also can influence arousal symptoms. So this is things including difficulty concentrating, a lot of tension, feeling irritable or engaging in risky behaviors. And we also know that these can be risk factors for perpetrating IPV, these avoidance and arousal symptoms. So if we just move to the top of the diagram, what are some of the pathways between, when we think about all of these structural factors underlie common mental health symptoms and problems, well, how can that then lead to potential likelihood of IPV perpetration and experience? One of the pathways we've detailed here is relationship quality and conflict, and especially relevant when thinking about IPV. So depression has been found to be associated with lower intimacy, can also be associated with reduced relationship satisfaction among intimate partners, and in doing so, heighten risk factor for experiences of IPV. Symptoms of depression can also influence an individual's ability to negotiate disagreements, to manage triggers of intimate partner violence and stress in relationships, and to even detect or leave abusive relationships. And this pathway also considers how feelings of depression can make people less interested in sexual intimacy, and this can be a source of relationship discord or conflict, and also increase women's risk of exposure to forced sex. So the second pathway here just considers the ways in which common mental health problems can erode individuals' self-esteem and resilience. And this can undermine people's self-worth, where they believe they deserve to be mistreated, including in intimate relationships, and so can be a risk factor for their exposure to IPV. And individuals with poor self-esteem may also be less able to protect themselves or leave abusive relationships. In terms of thinking about the perpetration pathway, individuals with lower self-esteem can be more prone to interpret whether it's real or perceived criticism from an intimate partner as more threatening, given the kind of lower self-esteem. And this can then more likely trigger a negative response, including violence. And then this final pathway on the right here is around the ways in which common mental health problems can affect emotional management and self-regulation. So this includes things around how anger, hostility, maybe irritability, common symptoms related to poor mental health have been identified as risk factors for perpetrating intimate partner violence. And traumatic experiences and depression can also influence a person's ability to regulate their emotions and impulses, including managing emotional reactivity, such as explosive anger, which can be a risk factor for use of IPV. This pathway also considers how poor mental health can reinforce riskier methods for coping with stress and negative emotions, such as substance abuse, and this can also heighten the risk of exposure to intimate partner violence. And while this isn't a strong focus, kind of looking at the role of substance abuse and alcohol abuse as in terms of a risk factor for IPV, my colleague Ruti Levtov is currently working on a similar review, but really highlighting the pathways between alcohol abuse and IPV, and to consider the potential of this as a risk factor prevention strategy. So stay tuned for that coming soon. Okay, next slide, please, Mudo. So The review, has a lot of emphasis on this diagram, but then tries to move into, given all of this and this evidence that tries to be synthesized, what can we take away that works to improve mental health, and particularly relevant for those of us in the violence prevention field and working to prevent intimate partner violence? And I think this evidence really suggests that efforts to improve mental health can and should be considered as part of a comprehensive strategy to prevent IPV. And also that programs that address structural drivers of poor mental health, as you saw, a lot of them are similar to structural drivers of IPV. So if you address some of those, you might be addressing both poor mental health and IPV. And this may explain why, as many of us know in the work that we're doing in IPV, sometimes our programs can impact women and men's mental health and mental well-being, despite not being designed to do so. And I think also vice versa. You can have mental health programs that are not designed to reduce IPV, but in addressing similar underlying factors, they may reduce individuals' experiences of IPV. So I think thinking about the synergies here, it's important to flag that a lot of the efforts and evidence to improve mental health focuses on an individual level, including those that can be provided by trained psychiatrists, like around clinical diagnoses, therapies, and offering medication. However, this mental health providers are scarce in many settings, and especially in lower middle income countries. And this review is really prioritizing what works in these settings. And so it's important for the violence prevention field to consider and be aware of strategies that can be implemented by lay people, which the global mental health field has done a lot already of work. And we're going to hear actually of an example today with the Friendship Bench of a program in Zimbabwe that can be implemented by lay people. So people who are not trained psychologists or psychiatrists, but are able to offer these interventions where these health providers are so scarce. And so next slide, please. So what we've done is in the review is just, again, this is not a systematic review on kind of mental health interventions and what works, but just try to flag different types of interventions that exist and there's some evidence around them, some of which also have evidence of reducing IPV, and some of which are just have evidence around improving or addressing common mental health problems at both individual and relationship and community levels, so thinking about different kind of social ecology of the model, and also more structural level factors. So starting with individual level, there's a lot of evidence from the global mental health field that brief psychosocial interventions that are offered by lay providers, so not trained psychologists or psychiatrists, can significantly reduce depression, anxiety, trauma-related symptoms, and some of these have been shown to also influence experiences of IPV. So one example is problem-solving therapy. This is an approach that teaches people ways to cope with problems more effectively, including through identifying kind of problems that they can control and problems that are out of their control, or prioritizing problems. And this has been shown to alleviate depression, anxiety, and distress. And the Friendship Bench is a very creative application of the problem-solving therapy. So you'll hear more about that just following me. Another one that some of you may have heard about is known as cognitive behavioral or processing therapy. And this teaches individuals strategies to manage kind of regular worrying or trauma-related thoughts, using techniques that can really restructure how they think, and just more awareness of how what we think affects what we feel and what we do. So a lot of evidence is as well around how these can address very effectively some of the common mental health problems we've been talking about today. There's also more and more interest in approaches that address more than one mental health problem. So for instance, maybe you can address depression and anxiety and trauma-related symptoms through combining multiple strategies that have been shown to work. And one such example is known as the common elements treatment approach. There's more about this in the review, and the Prevention Collaborative also has a dedicated program example on and it's also known as CETA for those who don't know more about it but would like to learn more. We also flag here interventions known as mindfulness interventions, which rest on a kind of theory of the importance of attuning individuals to the present moment, offering more acceptance and non-judgment to where they are. And there's some evidence as well that these can help treat depression, anxiety, and trauma-related symptoms. And other kinds of strategies, including meditation and yoga that can draw on some of the mindfulness theories, have been shown to promote self-awareness, self-compassion or compassion for others, resilience, recovery from trauma, and also enhancing one's emotional regulation. Next slide, please, Mudo. So the second kind of strategy we look at is what works to improve mental health more at relationship and community level. And so a lot of interventions at this level are focusing on enhancing social support as a strategy to improve mental health. And as we saw in the diagram, lack of social support can be a risk factor for poor mental health. And so interventions trying to integrate this can really be a buffer against mental health consequences in response to other drivers of poor mental health. This is also really important because, where people might understand recovery from trauma as a shared experience or something people feel more comfortable doing in group settings, these individual level strategies or therapies that I just gave some examples of may not necessarily be effective or be comfortable. So the review has a few different examples. One just to flag here is the Living Peace program in the DRC, which uses support groups to help men and their partners build cohesion and develop coping strategies after experiences of trauma in their settings. Schools can be a very important community level platform to improve mental health, to teach youth and adolescents skills around emotional regulation and anger management. So there's also a few examples of school-based strategies. And those of us who come from a violence field in the room are, very familiar with gender transformative interventions and how these are typically done to help communities confront the consequences of inequitable norms and how it impacts IPV. There's also been some evidence and some interest in gender transformative interventions to address some of the ways in which inequitable norms influence mental health as well. And again, I think thinking of the potential opportunity to integrate using gender transformative interventions, but integrating, addressing both poor mental health and IPV. Okay, next slide, please. So my last slide here is around the structural level strategies. So, it's interesting just to think about the strategies that address go right to the heart of some of the problems and address the drivers and shared drivers commonly of both IPV and mental health problems. So for instance, there's increasing evidence that cash transfers, anti-poverty programs, or welfare policies can significantly reduce depression, anxiety, and also reduce experiences of IPV. And it's not surprising when you think about one of the key structural factors underlying common mental health problems, as illustrated in the diagram, is poverty and food insecurity. And there's also some evidence that interventions that move people out of poverty can improve mental health as effectively as some of our more commonly known or gold standard individual level interventions to improve mental health, such as cognitive behavioral therapy or antidepressants. And so all of these reviews as well and evidence are referenced in the review if you want to learn more. But just to note that increasingly the global mental health field is seeking to address distress from structural factors and address some of those underlying factors. And this can include things like social isolation, economic stress and difficulties, and poor access to healthcare, education, and substandard housing. Okay, I think next slide, please, Mudo. So I'm now going to hand over to Dr. Rukudzo, who will share a little bit more about the friendship bench intervention, which is one of the ones also referenced in this review. And then we will come back and I'll share a little bit more about implications of this review and this work, but very happy to be able to pass over to our friend and colleague here to share a bit more about the friendship bench intervention in Zimbabwe.
Thank you, Dr. Erin, for the very comprehensive description of the reviews that you have worked on with your team as the Preventive Collaborative Group, and such on talking about a very important element of intimate partner violence. And I particularly like the fact that the review not only also speaks about mental health as being part of poor mental health as being one of the drivers of perpetration for intimate partner violence. And I think that will make sense when I start talking about the friendship bench, because it's an example or a case study of one of the case studies that you cite in your review that addresses poor mental health, in particular depression. And you will notice in most of the slides that I'm going to share that it is mostly women that are sitting on the bench as the lay counselors, and also providing the same care to women. So 84% of the lay counselors that the friendship bench have are women, and that's how the program was started. So based on my work and my experiences with the friendship bench, I thought it would be important to start with a bit of the context of the country. I know most people, when they read about low-income countries, we talk about the mental health treatment gap that is there. So Zimbabwe is one such country that has a similar treatment gap of about 70%, meaning 70% of people who need to receive the mental health care do not get it for various reasons. And one of those reasons is, despite being a country of 15 million people, there are only 19 psychiatrists in the country and just over 35 clinical psychologists. And this is all on a background of a country which has economic challenges, and particularly having, over 30% of people living below the poverty datum line, and also having a healthcare system that's somewhat literally on its knees, because the people who need to access health, it's either it's inaccessible, or when they actually are able to access the primary care facility nearest to them, they don't have the adequate personnel to do that, because in as much as we continue to train doctors, nurses, and clinical psychologists year in and out, because of the poor remuneration, there's continued brain drain, where we have lots of staff moving from Zimbabwe to other European countries or to the US. So that's just a bit of the background. And that's how the friendship bench was started, because that's a huge illustration of what the treatment gap, mental health treatment gap in Zimbabwe is. Next slide, please. So the friendship bench was founded in Zimbabwe, and this was out of a psychological crisis that had happened in the capital city of Harare. And the intervention was started by Professor Dixon Shibanda. Most of you might have read about most of the work that he has done. And he started working with community healthcare workers. So generally, the community healthcare workers in Zimbabwe are elderly women who are health promoters contracted by the government or by the city health. And these community healthcare workers go around, do health promotion work around other conditions, things like HIV prevention and care, TB, and other infectious diseases. But when this psychological crisis came to be, these were the only hands on deck that were available. And what a better way to just utilize the resources that you have. And that's how we started working with the grandmothers. So we call them grandmothers. I think those who are from the African continent sort of resonate with the role that a grandmother has in people's lives. So they're still affectionately called the grandmothers. And they were trained in problem-solving therapy. After this training, the problem-solving therapy, I think Erin gave a brief description of it. So the friendship bench model is basically problem-solving therapy, where the grandmother sits down on a bench, a wooden park bench, at a primary care facility or within the community. And they sit down, they have about 6 sessions where they're going through the 6 steps of the problem-solving therapy, which include identifying a problem, making a problem list, identifying a problem, setting goals for each and one prioritized area of the problems, and also strengthening the mind, opening the mind, and strengthening the mind. And once somebody has come to the bench and has had sessions on the bench, they are then invited to join a peer-led support group, which we call Sekubata. And the primary outcome of or goal of the peer-led support group is definitely to be therapeutic. But I think over the years, it also addresses one of the drivers that Dr. Erin was talking about, the issues to do with poverty and food security, because we have found that because of the element of behavioral activation that the peer-led support groups have, the initial groups would do crocheting, but eventually these sort of behavioral activation activities evolved depending on community needs, such that others involve themselves in things like gardening, others do baking, and it differs. But it has also become a very huge source of income, which actually addresses some of the problems that some of the clients come with on the bench. We can move to the next slide, please. So the work that the Friendship Bench does is obviously based and anchored in research, and some of that evidence is based on some of the work that the Friendship Bench team managed to do and publish in the JAMA in 2016. So this was a randomized controlled trial, which showed the significant decline in symptoms of depression up to 80%, and also suicidal ideation among people with high levels of depression. And how we measure this is that, when somebody is invited to the bench and the grandmother is sitting with them, they often first make sure that they do a screening, and they use a locally validated tool, which actually uses local and culturally appropriate idioms of distress, called the Shona Symptom Questionnaire, the SSQ-14. So it is 14 questions that you ask, and I think some people are familiar with things like your PHQ-9 or GAD-7 that they use to actually screen people. But the SSQ-14 uses the local language. It also uses local idioms of distress to do the screening. And so you take this screening score at baseline and also check after every other session. And that's how we've been measuring to date the reduction in symptoms of depression. You can move to the next slide, please. So one of the biggest questions is, yes, you have done this work in Zimbabwe. It seems like it's working. There's evidence for it. So what does it take to actually implement the intervention in an area? So the Friendship Bench then currently is working in over almost all of the provinces in Zimbabwe. And one of the initial steps that the team does once it has been put together, an implementation team, which has a team manager and other implementation officers who work on the ground and in the field, is to actually engage stakeholders, because in some of the earlier work that was done on what does it take to scale up the Friendship Bench, one of the most important things that we noticed is that partnerships are important. So engaging your stakeholders as a first step is one of those important things. And one of the biggest stakeholders for the Friendship Bench is obviously the government, because the government is the one that provides, in quotes and quotes, the hardware, and we provide the technical assistance. So the hardware being the grandmothers themselves, the primary care facilities that we work, which enable the intervention to be truly integrated within primary care facilities. The other important element or bucket is trainings. The trainings that the grandmothers receive, we do bear in mind that these lay health workers have the minimum education. Some have gone as far as secondary school, but some below that. So they do go through the problem-solving therapy training, and they also do get training on how to collect data. And in terms of the next steps is now, to increase demand for the intervention, we carry out mobilization activities that is going out into the community, providing psychoeducation, not just telling people about what the Friendship Bench as an organization is, but to raise awareness initially about mental health itself, because there's still a lot of stigma, a lot of myths and cultural myths that still needs to be demystified before people can reach out to such an intervention as the Friendship Bench. And then there is the invitation. Once someone has provided the gotten the problem-solving therapy, there's the invitation to the peer-led support group, which is the Seko Kubatana Tose, where they are able to share experiences among themselves as people with lived experience, but also to engage in the income generation projects. And then finally, there's the important bucket of supervision and monitoring that is needed. And this has two facets to it. There is the clinical supervision, because we know that problem-solving therapy is based on CBT itself, and there's obviously the psychological principles to it. So we ensure that people do have, for example, elements of empathy. Other grandmothers sitting down with clients and providing and showing empathy as they're providing care on the bench. And this is where the clinical part comes in, but there's also the monitoring of the program. Is it still effective? And we continuously do this. Currently, there is some stats that we're working on where, we did a 1-year follow-up after this RCT that I talked about, and it keeps showing that the intervention is successful, and there's sort of lots of changes that have been going on. We can move to the next slide. So, having shown all the success in Zimbabwe, initially in just one town, there has been a lot of scale up, initially a geographical scale up in Zimbabwe, where we're going in different provinces. But this has been made possible by the different partnerships that the Friendship Bench has. And like I said, one of those biggest partnerships is the government of Zimbabwe, the Ministry of Health, where the Friendship Bench intervention is recognized as an intervention that can be scaled to address some of the mental health challenges in Zimbabwe. And this has resulted in one of the biggest projects that the Friendship Bench is currently embarking on with the WHO, under the WHO special initiative called the Friends Program, which will see continued scale up of the Friendship Bench in Zimbabwe alongside the MH gap training, where you will have the lay health workers who are trained on the Friendship Bench, increasing in number, increasing in their geographical impact, as well as having another facet of the nurses being trained on how to prescribe antidepressants and also provide care and ensure that there's an integrated care and there's synergy between the public institutions plus the work that the Friendship Bench is doing. There's also been a lot of collaborations and partnerships with some other non-governmental organizations, particularly those who work in HIV care, those who work with commercial sex workers, and all these have included and adapted the Friendship Bench model and work together with them to improve both the mental health outcomes and, for example, the HIV outcomes in their programs. Next slide, please. So outside of Zimbabwe, there has also been different elements of scale up. So you will find that, for example, in Zanzibar, there has been a very successful program which runs under the HIPS program that the Friendship Bench has worked with. And this is one of the closest that looks almost like the Zimbabwe Friendship Bench program. But you will find that there are different ways in which the scale up has happened in different countries because of the different cultural differences and geographical locations, which is actually amazing because there's that actual cultural adaptation that needs to be there. And I think it increased the acceptability and the feasibility of the intervention. You will also find that there hasn't only been scale up or adaptations and trials of adapting the program in African countries, but also a movement towards the global north, where you have the program that has been tried under the New York Thrive program, and also in Canada, where it's still going through a trial, as well as in Vietnam, where they have done a study to see the feasibility of the intervention in people who undergoing methadone treatment. Next slide, please. So because there has been a lot of interest on the friendship bench, and different people, different countries, people with different cultures, there's been a need to put together quote unquote, literally a friendship bench in a box on what does it take to implement a friendship bench. If you just want to raise awareness, if I want to provide it, if we want to partner with you, what does it take? What do I need to start one? So this is what the team has been working on in the last, I think, year or so, to come up with a comprehensive package to say, if, for example, the collaborative groups approach the friendship bench and said, we want to start a friendship bench in Nairobi, we want to start a friendship bench in Rwanda. How do we go about it? And this is a package that puts everything and all the resources that one needs. And this will help in the scale up, particularly in different places and in different countries which have different cultures. And just as a conclusion, there has been, you can move to the next slide, please. Just to put everything together, the friendship bench is, yes, an example of a mental health intervention that is trying to address depression, but there has been some evidence within Zimbabwe, for example, on this study that Mwamuka and et al. Did with depression among HIV positive women, and we strongly support some of the things that Dr. Erin was speaking about initially in her presentation. And one of the suggestions and the recommendation of this paper was also to have programs such as the Friendship Bench coming on board and adapting the intervention such that it can be used to address some of these issues. Mm-hmm. And it is great to know that, you know, the intervention is somewhat shooting two of the risk factors for intimate partner violence, not just the depression, but also as a source of income when people go through the peer-led support groups that have an income generation element to it. Thank you very much, everyone. I think I'll hand over back to Dr. Erin, and I'll come back to address some of the questions that I see in the chat. Thank you.
Thank you so much. So I will quickly wrap up with some implications for practice all of this, particularly thinking about those of us doing violence prevention programming, and these are also outlined in more detail in the review. So the first is this element of providing training and support. So although the strategies outlined in this review can be provided by lay providers, they don't need to be provided by trained psychiatrists, it's still critical to think about how to ensure quality and needed training. So I like Dr. Rukudzo example of, you know, not only training your friendship bench providers on the problem-solving therapy, but even just how to do monitoring and intake forms. So what is the training that they need, ensuring that it's quality, offering ongoing supervision and support. And, you know, things we know from the field of violence prevention with facilitators of curricula, for instance, I think also applies, of course, to our work with lay providers. Another example is the CETA program, which I mentioned. Their providers, it can also be lay provider led, but they receive a 10-day quite intensive training followed by 6 months of ongoing coaching to then be certified as CETA providers. So a really kind of quality comprehensive training to ensure quality care. I think another really important implication for practice with this work is to address stigma. There's a lot of stigma of mental health that exists in nearly every setting. And I think it's really important to think about how you're framing these interventions, especially if it's an intervention designed to explicitly improve and address common mental health symptoms. And this can also be really important in terms of acceptance of programs, how we frame programs. Coming back to the friendship bench, I found it really interesting learning that one of the initial name for the friendship bench was to be mental health benches, but there was realization that this would cause a lot of stigma and potentially make people less willing to come forward. So they changed the name to friendship bench. So that's a nice example. I think just and it's so wonderful to have people from both fields in the room today, but just the importance of connecting mental health and violence and IPV in particular, and to really ensure that prevention practitioners who are doing violence prevention work better understand what are common symptoms of depression and anxiety, and to be trained to maybe respond with the things that they can do of psychosocial support, or to refer where necessary and recognize what is beyond what they can do. I think for many of the programs that we work in, or settings that we work in, if there is in conflict or post-conflict settings, if you're working with IPV survivors, in very impoverished settings, there is likely going to be a lot of trauma and common mental health problems, which are already just very prevalent globally within the people that you're working with. So it's really important to, I think, incorporate this in part of our awareness as violence prevention practitioners. I think the other implication for practice is around better understanding the pathways to and risk factors for common mental health problems in your particular setting or in the communities and individuals you're working with. So as we know in violence prevention programming, you really want to understand what are the key risk factors that drive violence prevention in this setting. And it's similarly important to understand what are the key factors, whether it's structural factors or more individual level or relationship factors that might be underlying some of the common mental health problems amongst the community or in the setting that we're working in. Next slide, please. I also think this, this is an area that we still need to learn a lot about. And I think ideally, any evaluations of mental health interventions, even if they're not being explicitly designed to address IPV, it's great to include that and to measure that, and vice versa. So our violence prevention interventions, even if we're not explicitly trying to address mental health, I think including that or improve mental health should be included. And this will help us better understand the pathways between poor mental health and IPV, and help to kind of bridge these fields that sometimes work quite in disparate ways. So I think just that's another implication for both fields. I think also thinking about barriers to access and to really ensure that no one is being left behind, identify and address any obstacles that might exist to individuals accessing interventions, both to improve mental health and prevent IPV. And interesting, again, Dr. Rukudzo, hearing about, less men, for instance, accessing the friendship bench. It'll be interesting to hear a little bit more about that and your experience with that. But just being aware of how we can make sure that these interventions are accessible to our primary and kind of target beneficiaries. I think the other implication is to collaborate with specialist services. Recognizing that some mental health problems require support or medication beyond the scope of what an intervention or what your intervention can do. However, I think, again, as you laid out, Doctor, in Zimbabwe, where there's less than 20 psychiatrists in a country of that size, this may sometimes just be impossible or very unlikely. I think, though, what is important when thinking about kind of those coming from a more violence prevention platform, just trying to, as we would say with adapting another evidence-based model, if you're interested in integrating some of what we know works to improve mental health, collaborating with organizations that work in this field, learning from them. It's really exciting to hear about things like the friendship box that, what does it take to integrate this? So I think that's where we can really be trying to learn from this field and to incorporate it into violence prevention programming. And the final implication is, throughout all of this, thinking about how do we maintain a gendered lens. And I think particularly with mental health, some of these interventions, mental health interventions I've outlined, some of them do a better or kind of could improve their job of being more gender sensitive or more gender transformative. And so drawing on what we know and have a lot of evidence from in terms of the IPV prevention field. And I think evaluations, it's helpful to identify how strategies to improve mental health can either reinforce or challenge some of the harmful gender norms, and how this might be linked to risk factors as well for intimate partner violence. So I will stop there, and we will now hand over back to our moderator, Rita, and also hear from all of you for some discussion and questions. Thanks so much.
Thank you so much, Erin and Dr. Rukudzo, for the presentations. We really got clarity, and you both have taken us not only through the brief, but also with that practical part of what the Friendship Bench is doing to address the mental health issues. So we have many questions from the audience, and I just wanted to say that if anyone from the audience would like to voice their questions, we also open to that. We'll start with a few questions that both of you can answer, and also we'll have some specific questions to each of the presenters. If I started with you, Dr. Erin, could you talk a little bit more about gender differences and how they apply to this topic of mental health and IPV? If you can just give a few,
Yeah, thanks. Thanks, Rita. Yeah, so the review does consider some of the different risk factors for men and women. So I kind of, as outlined in the diagram that I introduced at the beginning, but it does not, because it's really thinking about both IPV perpetration and experiences, it does not differentiate strategies that, for instance, work better for men or those that work better for women. But just to flag that this is a really important and ongoing area of investigation, and particularly given some of the different gendered risk factors that underlie common mental health problems. So yeah, it's a limitation, but it's an area that there's a lot more attention being given to. And because we were really trying to look at both pathways, we didn't differentiate in terms of what works to improve mental health by gender. But I think it's a really important question also with this issue of accessibility and ensuring, no one is left behind, and thinking about how we can incorporate some of our gender transformative interventions into efforts to improve mental health. And so, for instance, I'd be really interested in hearing from you, Dr. Rukudzo, about, you mentioned that men in the Friendship Bench are less engaged, and if that's partly because they're not the target beneficiaries, or if that's just because of certain barriers to access that you found with engaging men in mental health care, which I think is a common issue that you see globally as well. So thanks, Rita. And it would be lovely to hear a bit more about this topic. It's a really important question from Dr. Rukudzo.
Yeah, thank you so much, Erin. And if Dr. Rukudzo, you wanted to talk a little bit about that, the question that Erin just mentioned about accessibility, if men have been participating, because it is also one of the questions we have from the audience. So if you could at least talk a little bit about how have men been, if men have been participating to the program, if they haven't, what were the barriers, and if you can just shed some clarity to that.
Okay, thank you for highlighting that. Interestingly, I think it has been one of the, few areas that I've been looking at, which usually is, the unspoken side of the gender balance, where we know women are the vulnerable group in most societies, particularly in the patriarchal society that we live in. But you also find that there has been very high rates of suicide, not only in Zimbabwe, but I think generally among men, that has been, and it has brought about that big question about men's mental health and things like toxic masculinity and the like. So unfortunately, even with the Friendship Bench or any other intervention, I think the stats are similar in that the providers of the Friendship Bench, I think I saw someone talk about grandmothers. Why am I referring to grandmothers? So we generally, the Friendship Bench lay health workers are elderly women who provide the problem-solving therapy on benches. So they are commonly referred to as the grandmothers in their community. So that's why we also then keep on referring to them as grandmothers. So you find we only just have about 16% of those or less are grandfathers. So yes, we do have counselors, lay counselors or community health workers who are men, but there are very few of them, and very few of them do friendship bench work. And they've had struggles of their own. I think just a month ago, I was sitting down with one of them, just trying to understand their own experiences and how they think we can engage more men to actually come forward and be seen, because over 80% of clients who are seen on the friendship bench are women. And so, yes, when you talk about access, in as much as the benches are available in all spaces, the primary care facilities or in communities, without any gender discrimination, you still find more women approach the counselors and sit down on the bench, and definitely very few men.
Thank you so much, Dr. Rukudzo. And we have questions from participants. And again, feel free to unmute, to raise your hands, and then we can give you space to talk to your question. So there is a question from Elizabeth. Elizabeth would like to say to check if you have should like to hear more about the best practices, things like tools, scales, and for measurement, especially measuring mental health impact on various interventions. And if you don't mind, Dr. Rukudzo, if you could link that question to how this has been brought to scale in different contexts, if you could talk about how the program may have changed in the different contexts, if there are some points we should consider if you think about, adapting and taking that program in some other different contexts. Dr. Rukudzo?
I would try and answer that if I got it well, but Elizabeth can always share if I didn't get her first question correctly.
Yeah.
So I think the first question was referring to the different screening tools, and maybe if I can make mention particularly to the one that the friendship bench adopted, which is the Shortness Symptom Questionnaire. So it's basically a 14-item questionnaire, which is very easy to use. It uses yes and or no responses. In the last 2 weeks, have you been feeling low or sad or struggling to sleep? Questions, or rather what we call idioms of distress. But it is actually a questionnaire that was validated in Zimbabwe and made in Zimbabwe using the local language. Like when you ask someone, what does it mean for you when you say you are depressed? I'll give you one very short, interesting story of somebody who migrated abroad and was being seen by their psychiatrist. And there is one term that the friendship bench used because it is hard to come up with a word for depression itself in our local language. So after years of seeing their psychiatrist and they were not able to express themselves well, one of their psychiatrists came upon some of the terms that we use, and the word is kufungisisa, which in literal terms means thinking too much. And the day that their doctor said kufungisisa, it sort of resonated with them, and they really felt like, yeah, that's what I'm trying to express. That's what I'm trying to mean. So that's a screening tool that we use. And the reason why we use screening tools in mental health is to have an objective assessment of where someone is. It obviously does not take over a mental state exam that a psychiatrist does or a nurse does, but it's an objective assessment for us to be able to measure impact of an intervention. So other people choose to adopt things like the PHQ-9, the Patient Health Questionnaire 9, which is a 9-item questionnaire to screen for depression. Other people use things like the Generalized Anxiety Disorder 7 questionnaire, which is 7 items, and it screens for anxiety. So people use different sort of scales and screening tools, but the most important thing is they help us to be able to measure the impact. Is what we are doing working? And if it is working, how good is it working? So I hope I have answered Elizabeth's question on that. And then on the second part of your question about what has changed, interestingly, there are also small things that have changed as we have been scaling up even within Zimbabwe. Currently, having had trained over 1,600 community healthcare workers, because there are certain things that come into play. For example, the supervision starts looking different. It means you need to have layers of supervision structures. And these are some of the things contained within that friendship bench in a box to say, when it comes to supervision, clinical or otherwise, what kind of supervision structure do you need? So you have, for example, one first layer is the supervision within the grandmothers themselves, because as you're training them, you can actually identify some who are able to provide the intervention better than others, so they can provide that first level of supervision for their other lay health workers. Then you have the nurses that they work with that provides another layer of supervision. And there's another layer where you can now enroll in the doctors and the psychiatrists. So then that addresses the challenge that we have of the treatment gap, because we are not able to have a psychiatrist where there's every friendship bench in the over 160 facilities that the friendship bench is in. So you'll find that this has evolved over time. Initially, when you have a little group of lay health workers, you're able to supervise them individually, but that changes. There's also been changes in incorporation of, for example, technology, particularly which was accelerated mostly by COVID-19. I know lots of negative things happened, but I think one of the positive things is it also accelerated the work towards the use of things like WhatsApp platforms as a way of providing mental health support. So you will find there is the traditional, in quotes, friendship bench, but we also have a youth friendship bench where you have more of a peer-to-peer counseling happening. And this is mostly based, it's online based, where you, the counselors actually provide care over platforms such as WhatsApp, or even online, or even voice calls, depending on one's preference. So there's been lots of changes even within Zimbabwe itself, and you find some adaptations that are still ongoing in countries like Malawi, where there are several studies going on around the friendship bench and its adaptation. Even in Zanzibar, because of the cultural differences, we appreciate that, like, for example, in Zanzibar, you have predominantly Muslim culture, which is different from where the friendship bench was initially founded in Zimbabwe, which is predominantly Christian-based. So all those little differences bring about, small tweaks that happen to the intervention, but it does not take away the basis, the backbone of it being problem-solving therapy.
Great, very, very good answer. And that answered some of the questions that I were already asked in the chat box, and especially in relation to COVID-19 and how it has affected the programming. So thank you for the clarity of your answers. So to give you some seconds to breathe, we're gonna shift and put a question to Erin. So Erin, you emphasized many.
Could I just quickly come in on that question before we switch gears?
Absolutely. Thank you.
Just coming back, Elizabeth, to your question on kind of measurement and evidence. And this is mentioned in the review, but I think it's just important to recognize the limitations of the existing evidence base on what works to improve mental health, which seems to be still quite skewed to kind of manualized interventions that come from a more clinical or individual framework, even if those delivered by lay people. And I think partly this can be explained by the fact that such interventions lend themselves more easily to randomized control trials. I think, as many of us know who work in the violence prevention field, the RCTs are really considered gold standard for evidence and how we measure impact. And it seems to be very similar in the global mental health field. And so just kind of recognizing that, there's less attention to some of the psychosocial or support interventions. This can include things like community mobilization, community organizing that is used to support healing from trauma, or also the kind of wealth of interventions that involve movement or music or other expressive mediums. And so just, I think it's really important to continue exploring the contribution of those approaches beyond the kind of mainstream evidence base. And particularly identifying how a lot of feminist and women's rights organizations are already working to strengthen emotional well-being, to strengthen resilience, and self-care and healing from trauma, which just might not be well captured in the kind of impact evaluation evidence base or literature. So just one other thing, and thank you for that really important question, Elizabeth.
Thank you so much, Erin. I'll pause a little bit on the question we wanted to ask you, Erin, and go back to Ananthi's question. So Ananthi has a question. Have there been any linkages to maternal mental health support and the Friendship Bench program? If you can talk to that, Dr. Rukudzo.
Thank you for that question. So yes, there has been a little bit of work around that. There is one, I think I'll share with the host here. There has been one a sort of study that has been done around postnatal depression and the Friendship Bench, where there was one arm which received the group problem solving therapy and one arm that received amitriptyline, which is an antidepressant. And there was a significant improvement in reducing depression as well for postnatal depression. And this one had to use a tool that is appropriate, the Edinburgh postnatal depression scale. So yes, there is some evidence towards that. There's also some ongoing work in Malawi. There's one of their studies in a registered clinical trial that's currently ongoing, which is adapting the Friendship Bench for HIV-infected perinatal women in Malawi. So it would also be great to look out for that paper when it comes out. So yes, there has been some work around that, and it seems that there is some effectiveness as well.
Great. Thank you so much. I would like to check if Heather, you wanted to unmute and talk to your question, but if you're unable to, I'll just go ahead and read your question. It's about the criminalized population targeted by the program. Heather, do you want to unmute and speak to your question? Okay.
Hi, can you hear me?
Sure, yeah, we can hear you.
Thank you. Yeah, I found this intervention to be really interesting, especially in terms of its applicability to marginalized populations such as sexual and gender minorities. And I was wondering if there's been any anecdotal evidence or evidence of that being implemented with those communities. Thank you.
So yes, the Friendship Bench has worked with some of the marginalized communities. Obviously, just bearing in mind that, for example, with the LGBT community in Zimbabwe, it's still legally, it's not there, but there is no legal statutory that recognizes the LGBT community in Zimbabwe, so it remains illegal. But there are associations that do support and provide support and for the LGBT community in Zimbabwe. And we work, they also work hand in hand with the Friendship Bench and provide the intervention for the Friendship Bench. But like, you know, what we were saying in terms of the evidence, do we have documented evidence for that population? Not just yet, but yes, having the Friendship Bench being adapted or being provided as part of the interventions for that community, yes, that has been available. There's also been a lot of work with particularly one of the organizations that work with commercial sex workers, which particularly looks at things like even intimate partner violence, which also looks at HIV prevention and care. So yes, there is that relationship and collaboration with the friendship bench intervention, because one of the biggest things, because these are marginalized communities, there's a lot of stigma that is there. And sometimes what the friendship bench does is actually provide technical assistance such that they have their own counselors who are equipped with skills to provide the problem-solving therapy, which makes it easier for people within these marginalized communities to find a counselor who they are comfortable with, who they can share with their issues.
Great, thank you. And I can see already in the chat, some people would like to connect more with you to know how they can work with you to adapt the friendship bench. So yeah, that's why we have the webinar. So we'll make sure that you can connect. A question that can first go to you, Erin, and feel free, Dr. Rukudzo, if you want to talk to that. Erin, you emphasize many different ways to address mental health as a strategy to prevent violence, right? What's the role for organizations that typically do violence prevention work? And if you can clarify, what can those organizations do within the limits of their knowledge and expertise still to deliver to that?
Thanks so much, Rita. I think this comes back to really kind of knowing your setting and intervention, but being aware of, if you identify that common mental health problems are a key driver of either IPV perpetration or experience or both in your setting, if you don't kind of think about strategies or integrate strategies to specifically address that, your intervention might not work as effectively. This might be one of the things that's driving IPV that you're not able to address. So I think being aware of that it is a really useful kind of first step. I mean, and it might not be a significant driver in your setting, but it also might be something that is very significant and that if you don't give enough attention to, could limit the effectiveness of your intervention. I think the other thing is just to think about entry points or opportunities that might already exist on where some of these, and this is where this review was just trying to highlight some of the strategies that, the wealth of strategies from this field. It's a very huge field as well, global mental health. But for instance, if you're already doing a kind of cash transfer or livelihoods program, maybe just thinking about how that might be affecting both IPV and mental health. And so including that as part of your monitoring or including that as part of your evaluation, because it could help you better understand, are you affecting or improving the violence through addressing the food insecurity and poverty that might be driving violence in your setting, or is it also through the pathway of mental health, and just help you kind of you better understand how and if your intervention is working. And so I think that's also thinking about the role of M&E as well. And then I think just, I think as we recommend with adapting evidence-based models, if you're really interested in a strategy or incorporating it more, whether in a curriculum that you're already doing or in some of your community mobilizing or whatever kind of type of intervention you have, I think trying to just ideally talk to the originators or talk to those who have implemented this program, try to draw on best practices and think about how you can integrate that into your own quality programming.
Great, thank you so much, Erin. There is a question from Annette, which also I think will link to how organizations can do this work. And she asked about what has been the role of mobilization or sensitization to seek the services of the friendship bench, and how do you address stigma around mental health? I think that goes to Dr. Rukudzo. If you can talk a little bit about that.
Thank you for that question. I think while we're just on the area of measurement, it is very hard to measure how far you have gone in addressing stigma when it comes to mental health. So obviously that's been a challenge. We know we've got a certain impact. We have carried out a certain amount of mobilization activities. That is, you have gone out, you have spoken about mental health awareness, why it is important to take care of your mental health, symptoms of depression, symptoms of anxiety, when to reach out, how to reach out, and some self-help guides, but you don't know what kind of impact that has on the actual stigma. But we assume that based on, over the 10 years of the work of being in the communities, there has been an element of addressing stigma. And we basically measure that by the amount of people who are reaching out to the friendship bench, sort of as a proxy, but definitely it is hard. And the mobilization activities take different forms. There's obviously the online presence, there's the physical mobilization, which starts even at the primary care facility. Those who are familiar with what, primary care facilities in most African countries look like, people come very early in the morning to the clinic. So you've got a good number of people. So these community healthcare workers or the nurses use that opportunity to have a small mental health talk to raise awareness, but they also do the same as they are moving within their communities. So you find among some of the lay health workers who work with the friendship bench, about 30% of them only focused on mobilization. That is, they are raising awareness within the community, because majority of their work, they carried out within the homes on the communities where they work from. So while they're doing their health promotion work, whether for HIV, for TB, for cholera, or for COVID-19, they also use the opportunity to raise awareness about mental health as well. So that's an example of some of the mobilization activities, but obviously they take various forms. And for example, for the youth friendship bench, that also takes an entirely different form, because they target areas where they potentially can find young people. And there's been a lot of focus on colleges and universities for us in the last few years.
Thank you so much for these clear answers. And I'm checking the time, but we still have a few minutes. So there's a question that I can direct to you, Erin. So thinking about men, and the question is from Abby Hatcher. So thinking about men specifically, has there been much evidence to causally or longitudinally link IPV victimization to mental health consequences, or to connect mental health problems to future perpetration? Yeah, and also to know if there is a cross-sectional data, but not sure about causal linkages. So if I didn't do justice to your question, Abby, feel free to unmute, but I think, Erin, you got the question, if you can address it.
Thanks so much for that question, Abby. So I can speak more to the second part of the question, because this review really focuses on how mental health problems can lead to future perpetration and not the first pathway. But there is a little bit, more on that. I think with the, you're right, there's definitely more cross-sectional data. I feel like the data kind of reviewed in terms of causal linkages is particularly strongest with some of the childhood trauma and adversities. So the kind of evidence that, for both boys and girls experiencing trauma and childhood adversities, including violence, can increase their likelihood of developing trauma symptoms and depression, and that this can then be a risk factor for future violence. And I think there's still, though, a better need to understand, there's a lot of evidence around the ways in which exposure to violence as children or experiences of violence increases the risk of IPV. And I think better understanding, how mental health could be a mediating factor for this, with more kind of, as you're saying, Abby, causal evidence is really important. I think the other area that, coming back to the diagram around the poverty and food insecurity, there is some kind of indication of gender differences. And as I've mentioned, the review doesn't differentiate as much as, there's a lot more evidence that could be doing of differentiating between men and women, because it is really interested in both pathways. But there are a few examples and some definitely evidence reference. And there was one study For instance, in South Africa, which found that food insecurity and childhood trauma was a significant risk factor for men's substance use, but also poor mental health, and that this was a strong mediating factor for their risk of perpetrating IPV. So that's just another study that's also example flagged in the review. But thanks for your great question, Abby. And I think, I think there's a lot more need to unpack and untangle the causal mechanisms at play here, and particularly where, is it the violence driving the mental health that's driving, or vice versa, and I think, so I think better understanding the ways in which these two are linked and how that is different for perpetration of violence for men or experiences of violence for women. So thanks for that great question.
Thank you so much, Erin, and I hope Abby got the response. So we're about to close the webinar, and I know there are some people who are interested in how they can reach out to you, Dr. Rukudzo, and the Friendship Bench. And there was one question earlier from Annette asking if the Friendship Bench was already available, the pack, I suppose, or if it's still being worked on, and how they can access that. I guess if you can just talk to that or give further reference to how they can reach out to you, sorry.
Confirm this is me wrapping up. Rita?
No, I just wanted to say if there are so many people in the chat and also who wanted to know if how they could access the program. I guess it's for adaptation and use in their different contexts. So just an indication of how they can, as we had a few minutes to use before we close.
Oh, great. So there is, I think the Friendship Bench website has been posted. So yes, the Friendship Bench has been in existence for over 10 years now. So yes, but because iteration and research, anchoring research is part of, one of the core values, that's why you continue to find that there is continued ongoing work, but the intervention has been running long and hard. So if you do go on the Friendship Bench website and you'd like to be part of only the community minds, where you can get more resources and information about the Friendship Bench, you can sign up to do that. But if you'd also like to adapt or have the intervention or have your own Friendship Bench in a box where you can implement in your country or in an existing program or intervention, you can also send a message. So you will find, it's only that I've forgotten which particular tab to go onto on the website, and then you can reach out. And we do have a team that works with our partners who work with you through the process of how to go about that. But basically, it's not a very difficult process. There'll be, a bit of suitability checklist that goes on. And then we go into the Friendship Bench in a box. You explain what it is that you would like. Do you just want the Friendship Bench to empower your team or provide technical assistance? Or would you like to learn from people here in Zimbabwe and come over? So people, choose different things. Some people want to just carry out a research project in their area. And many a times we believe in starting off as a pilot project so that we can derive lessons from it before, going and scaling up in whatever area or with whoever, a partner that we've chosen to work with. So please do feel free to reach out and for collaborations.
Thank you so much, Dr. Rukudzo. There's Lori's hand that is up, and Lori, please come off mute and then share your idea. Thank you.
Yes, I just wanted to say one final thing, alert people, is the Prevention Collaborative over the last 8 months or so has been doing a review of all the curriculum-based programs that are geared towards preventing IPV. So we've really looked at them, compared them, tried to analyze their strengths and weaknesses. And in the next period of time, one of the things that we want to do, or that we're planning, is a meeting to bring together people from outside or from allied fields like global mental health and or things like self-help support groups or behavioral economics, or these different fields that are sort of have potential insights that we could integrate into our group-based or our couples-based interventions to strengthen them. So just to, we will let you know when that's coming to pass, but going back to the question about, well, how can IPV programs best take advantage of this? There are ways, I think, to take key insights and skills building that have emerged from the mental health field and integrate it into, for example, couples gender transformative programming or the like. So just stay tuned for that. Thanks.
Thank you, Laurie. We're at the top of the hour, but Erin, you had one word to wrap up, and we'll show people how we can stay connected. Thank you so much. As Erin and Rukudzo take 1 minute each to wrap up. Thank you.
Sure, I'll be less than a minute. I know we're at the top of the hour, but just following up on what Laurie was saying, I think there are great opportunities that exist to harness improving mental health as a violence prevention strategy. And, really encouragingly, some have already been shown to improve mental health without kind of including specific content to do so or explicitly trying to do so. But I think if there's a little more intentionality and drawing on some of this, it could be harnessed even more. And I think that reverse is also true, that efforts to improve mental health could be even stronger and more effective with efforts that incorporate some of the evidence and efforts to prevent IPV, especially given the ways in which violence can have significant mental health consequences. I know that wasn't a focus of today's session, but just the ways in which these are so linked, and also some of the structural factors underlying mental health also underlie violence. So just to end on a note that I think interventions that incorporate elements to address both IPV and poor mental health and kind of come together may enhance the impact, even things like sustainability or cost effectiveness of impacts on both mental health and IPV. Thanks so much, everyone.
Thank you so much, Dr. Rukudzo. Any word of closure?
Just my last words is that the importance of continually looking at the community that we're working with, whether we're addressing IPV, we're addressing mental health, or the intersections of the two. And I think the biggest success of interventions such as the Friendship Bench has been the cultural element to it, being culturally appropriate for your community, working with the grandmothers who are viewed in that cultural position, using local language, using local screening tools, all increase acceptability, visibility, and they address things like stigma and ultimately some of the social determinants of mental health, your poverty, food security, and ultimately improve other associated factors such as intimate partner violence. So just being culturally appropriate with interventions that we do and continuously learning from them is very important. Thank you.
So thank you so much, everyone. We're coming to the end of our webinar. We'd like to appreciate our speakers, Dr. Rukudzo, Dr. Erin. This has been really great and informative. Thank you all for the questions and for the interaction in the chat. We wanted to say the recording will be available and sent to you all. Please feel free to share, especially with your colleagues and friends who were not able to attend. And also you can access all the other previous webinars from our website. So this is how you can stay connected with us, and we look forward to seeing you again on some of our other webinars and offerings. So with that, thank you and see you all. Bye.